Hey, out there, let's do this, America. That's right. This is DrMikeSevilla live for Thursday, August 2014. It is 2:09 Eastern Time. Sorry for starting a little bit late. Here at Family Medicine Rocks World Headquarters, it feels like a crisp 65 degrees Fahrenheit. I'm very excited about today's interview, which we'll jump right into after I introduce our guest. Ryan Neuhofel, DOMPH, is the founder of New
A dump.
That's right.
I think that's the first time that's ever been said ever.
He's in Lawrence, Kansas, and you can find more information at newcare.net. Served as chief resident at the University of Kansas Medical Center, specifically, obviously, and especially family medicine. We'll be talking about direct primary care and also his experience at the 2014 annual resident student meeting of the American Academy of Family Physicians. And I did want to share this quote from his website, which you can go to at newcare.net. And he says, quote, "I started my medical education with a vision I recognized that would be extremely difficult to realize without foregoing a new path. The idea of directly providing my community with personalized and high-tech primary care has been many years in the making. My dream became a reality in December of 2011 with the opening of New Care in 2012 and 2013. We built the foundation of a medical home that provides affordable, quality care to our friends and neighbors." Thank you for being here, Dr. New. Great to see you again.
No problem. Thanks for having me.
So I first heard about you about 2 years ago on the internet out there, and I know you were doing and are still doing a lot of speaking, but it was out there in the Kansas City area. The meeting was called Partnership with Patients, and I saw people tweeting your talk, and that's when I first started to learn about direct primary care. Then as we started talking and interfacing, we found out we have a mutual friend, Dr. Deb Clements, who we've known for a long time, and she told me all about you. So and I got to come out and
she does know a lot about me, I guess, since she was my program director in residency.
And I got to see the office earlier this year, and it was great to kind of see the setup there. Just so thanks for the time today. It's great to talk to you again.
Yeah, no problem.
So let's kind of just jump into things. I mean, we were talking before we went live here that you've been kind of telling the story for a number of years now, and hopefully it's gotten a little bit better than it has been in the past few years. But when you talk to patients, when you talk to the community about the topic of direct primary care, what do you tell them, kind of basic wise?
Well, it's funny because a lot of people in my community know who I am and that I do something different, and most people think cool. But most people, that's kind of their level of thinking until I directly talk to them. Some people have an idea of kind of how this works, but a lot of people are kind of just, well, that's the doctor who does that kind of different weird thing, and they're not really sure of the details and the value of what direct primary care really provides. So a lot of times when I talk to people, they're like, "Oh yeah, I've heard of you, and I've known about you since you opened 2 years ago." But they didn't really realize the details and specifics. A lot of times because I think people are just kind of disengaged from healthcare in general, and a lot of times people are kind of just floating along and doing their healthcare without really giving a lot of thought. We of course would never do that when we purchase a car or a cell phone or a blender. We're going to do 20 hours of research on those type of things and services, but people kind of, unfortunately, because of the current system, are disengaged. So a lot of times it's just basic education about what primary care is and how direct primary care is different and better. But those details often are elusive to patients, even with what they're doing with their healthcare now. They get their insurance through their job. They really don't think about how their insurance works or how care works. Nor do they really think about their primary care and what it really means to them.
And it's just been really interesting, kind of, especially probably in the last, 6 months or 9 months or a year, is that there's more and more people, especially on Twitter and on social media. There's been different organizations, medical organizations that have popped up in the past few months, telling the same message and are I mean, I know you've been approached by this, but are you kind of seeing more of a momentum by some of these medical organizations kind of?
Absolutely. The AAFP, I guess when I started was kind of on the sidelines. I don't think they really had said much about direct primary care when we started, and I'm certainly not the first one. There's a handful or more of docs around the country who had started several years before I had, and but the AAFP hadn't really commented much on it. And even when I started, they really didn't have much of a policy or much of a statement on it. But in the last year and a half, they have done several things, and in general have been very supportive and issued positive statements regarding it. And they also have created recently an interest group. They've had some kind of tools, practice management type tools. And so yeah, it's been great. And then I recently had the opportunity to speak on at the national conference on the panel representing innovative care, direct primary care, I guess was who I was representing. So it's moved from them not really recognizing this as a practice model 2 or 3 years ago to now there was 4 docs in the whole country representing, there was I believe someone who is considered rural, someone who is considered academic, and then someone who is considered underserved urban, and then there was a direct primary care, which awesome. They asked me to participate in that. So it's kind of changed drastically in the past year or two. With the AFP, there's several other organizations who have been kind of in this arena. I'm actually on the board of a recently founded organization called Direct Primary Care United, which is basically me and a handful of other direct primary care docs. That organization has just got off the ground. They really don't have, they haven't done a lot of activities yet. But yeah, so there's some specific, but I think really the potential of the AAFP getting involved is by far the most powerful.
And it was very exciting that you're invited for the resident student meeting out there, and we were kind of chatting before we went live there. How was that experience for you? Can you kind of give the viewers an idea, like how many people were in the room and what was that experience like?
It was great. I had been to the I guess it's called the national conference, but it's primarily for students and residents. I had been in past years. I think I had gone once during either late medical school or early residency. And it's usually a pretty big event, but apparently this year it was the biggest ever. I think total in attendance was over 3,000, somewhere close to 4,000. And each morning they had a main presentation, and so the second morning I was on that panel to do that, and I think there was probably 2,000 to 3,000 people in the room, primarily residents and students. And it was about probably 45-minute or so panel discussion, ranging a pretty broad range of family medicine topics. So not specifically on direct primary care, but of course, whenever I kind of am responding to those type of inquiries, it usually does come back to direct primary care for me. So had the opportunity to speak there and answer those questions, kind of coming from my point of view. And then afterwards, had some really great conversations with students and residents who were really interested.
So what did you tell them? Did you just basically kind of shared your story about going to residency, and you're frustrated with the current healthcare system, and you wanted to do something radically different?
Yes, I'm a radical. Revolution. Yeah, I mean, it wasn't about me specifically, but a lot of the topics that came up, that come up in any area of family medicine, things like compensation, respect amongst your peers, work-life balance. All of these issues feed into the reasons why I did direct primary care. And so any time that we're discussing family medicine and the future of it, all of those topics that kind of were discussed, to me, direct primary care kind of solves a lot of them, and in addition to providing better patient care. So yeah, I mean, almost all of the topics that came up relate back to what I'm doing and why I'm doing it. But they didn't give me like a whole hour to just give my personal story. Maybe next year.
Yeah, maybe next year. Um, so when you were talking with students afterward,
Mhm.
did they have a little bit of a grasp on it, or did you really have to be real basic about your explanation of it again, or how was that?
It was a big spectrum. There was several students and residents who were very familiar with direct primary care and were planning on doing it, and had researched it thoroughly, and kind of understood the concept, and were kind of asking me some of the details about how my practice works. But then there was also some students and residents who came up to me who had never even heard the term or concept and just said, "Tell me exactly what do you do?" So there was both. I mean, there's people there who the very first time I think they'd ever heard about direct primary care was me on stage that morning, and then there was other students who'd done a research project. There was the poster presentations they give. There was a student from Duke who'd actually done a research project and a poster presentation on direct primary care. And I met him a year and a half ago when he was doing the study, and I guess I was included in that in some of those statistics. So yeah, it kind of ran the gamut. People who were very familiar, and then people who said, "Now what are you doing? House calls and you're on call 24/7 and a membership? What is this even about?" So yeah, it kind of was both. But I would say half of the students were fairly familiar and enthusiastic, and were kind of already very interested in it.
Now, a question that I get a lot from people is that, how is this different than the term concierge medicine?
Mhm.
I imagine you get that question a lot. How do you respond to
Yes.
that?
Well, I mean, concierge medicine is a term that means a lot of things. And so direct primary care isn't monolithic by any means. There's different variations on the model and different ways you can do it. But concierge is even more vague term. And when people say concierge, I don't really know what that means. I mean, other than people think it sounds fancy and expensive. But when you actually get down to the actual practice model, most of the doctors who have, over the past 10 years, who have called themselves concierge, are still operating in the insurance world. So they're still contracting insurance. Their patients still have insurance. They're still paying copays. And then on top of that, they charge their patients an extra membership fee to get special access, to limit their patient panels, to give them white fluffy towels and red carpets or whatever else they do. MDVIP is by far the largest organization involved in that. And I think the vast majority of their doctors are still insurance-based, which I don't begrudge them for doing, but it's not a fundamentally different way of practicing medicine. You're just charging people extra so you don't have to have as many patients and giving them better access. Whereas direct primary care, by definition, at least in my definition, direct means you don't have any insurance contracts. You're not billing third parties in any respect. And there's different ways you can do that. And a lot of the services that I offer are termed concierge. I do house calls. I'm on call 24/7. We do email, text message. So I don't use the term, but I think everyone deserves and could get that level of care. So to me, that should be the standard, not the exception. And my wife sometimes says I'm a concierge doc. I'm just too stupid to charge like it.
And I've read and I've heard you speak before, and you've said many times that this model of care, this model of medicine that you're practicing right now is something that, that's why you went to medical school, and this is the type of care that you've always wanted to do.
Yeah, I was really, I guess, naive. I think on my Twitter handle it still says I'm naive, but less so every day. I went into medicine not having a background in health or medicine in my family at all. I mean, I don't think I had anyone in my family. So, I went to medical school because I was a nerd, and I had a short shadowing experience with a family doc and thought that it was amazing and that's what I wanted to do. But I didn't really understand the system and the healthcare system at all. So I kind of came into it blind, and very early on realized that I spent all this time like trying to figure out the science behind medicine and the clinical utility and application of it. But when you actually got down to doing it, I spent more time filling out paperwork or watching my mentors fill out paperwork than actually time with patients or discussing a diagnosis or treatments. And that was very shocking to me. And I just realized very early on that it shouldn't take 45 minutes to document a sprained ankle. that took us 5 minutes to review. Nor is it fair to give a patient with very complex medical problems and lots of medicine 7 minutes of face time, yet document for 45 minutes after the visit. So yeah, I mean, I realized very early on that the system was kind of broken, and patients weren't satisfied, and doctors weren't satisfied, and I wasn't really sure who was satisfied in the system, or at least I never met those people. So yeah, I think I just came into it kind of naive, and then from that moment on, I just thought I really still want to be a family doctor, and I want to practice medicine, but I thought, well, maybe the next setting would be better, and so I experienced, like most medical students, a variety of different settings, anywhere from like a nice suburban private practice to academic medicine to a safety net clinic, and I just didn't see myself practicing in any of those settings and being happy long term. So that's kind of where it all started for me, and then I saw a few docs around the country doing different things, and just basically said, I think I can do this without all these other entanglements and all these other things, and kind of started with a blank slate mentality and built the practice.
Now you mentioned some of that data from Duke. Was that cost data? Was that quality of care data?
Yeah,
was it both, or what was
Simon, his name is, if you guys want to look him up, Simon Testafarian. Man, I'm going to butcher his name here, like everyone butchers my name. Simon Testafarian, I believe, something along those lines. So yeah, it was more of just like a survey data. He talked to a bunch of docs who, and again, the definitions kind of get murky here when you say direct primary care. And even that was one of the things that he came up with, is it's hard to do survey and quantitative data on this, because my definition of direct and primary care might be different than other people's. So a lot of it was just survey data about, like, how many patients a day are you seeing? What are your membership fees, or are you charging a membership fee? What type of service and access and features does your practice have? What's your patient panel size, etc. So it was more of just a survey data, and trying to get a scope. And I talked to Simon afterwards, and even he did his survey, I believe, about a year and a half ago. And even in the last year and a half, things have drastically changed in terms of pricing. I mean, I've seen. I think I've tried to kind of rush there faster than other people, but we've seen the price points of direct primary care come down steadily. So whenever you hear in the media, oh, such and such doctor's charging, $400 a month or even $100 a month, most of the doctors who are growing fast and opening practices are charging much less than that, including me. So it's very difficult, and things are moving very fast, and it's hard to do things like research or get a kind of a media. I see it often, the confusion between what is concierge medicine and what is direct primary care, and oftentimes they get lumped together and they're the same thing, and the prices that get quoted in the media are often double, triple, quadruple whatever I see actually the doctors I know around the country doing this. So I don't know if that's just a relic from the whole concierge thing that was 5 or 10 years old, but there's been a lot of change in the last year.
Yeah, you mentioned, I mean, that everything is moving very fast, and always with these new models, whatever it is, people ask the quality question. Does this does this improve chronic care? Does this keep people out of the hospital? And I know with these different definitions of direct primary care, or even with different models of medicine, it's hard to compare apples to apples and say, oh, this model has higher quality than that model.
Well, and I think as someone who has a master's in public health, I'm very interested in all of that. And there are some people out there trying to quantify the quality improvements operating under this model, however you define that. I mean, I can tell you anecdotally, again, being an MPH, I should never say such a thing. But I mean, it's remarkable. I mean, I have story after story after story of patients who previously had uncontrolled chronic diseases for a number of reasons, either because of cost, or they're just busy, and for all the different reasons that people don't kind of follow through with doctors' recommendations or keep on their medicines. The direct model solves a lot of those hurdles, and I think that's ultimately what it is if we make care easier, most people, not all people, but most people will do better if we give them, if we can give people same-day visits and communicate with them in all the different channels. If we can, save them money on their medicines and make it easier to get their labs, and all of these things, it makes their care better. And I have, countless stories of people who maybe even had insurance, who had never had an A1C less than 8 and 10 years, and they were fairly committed to their care, but there'd always been some reason or some hurdle why they couldn't quite get good control of their diabetes, and they came to me And not that I'm a great doctor, I didn't do anything magical that other doctors weren't doing, but I spent more time with them, educated them more, made it really easy for them to get their labs and follow up with me by email or some other channel. And within 6 months to a year, their A1C was 6.5. I mean, I can tell you story after story of people who had those situations, and it's not because the other doctors are dumb or don't care. It's just because some people require more time and effort. And if you can invest that time and effort, most of the time people are going to do better.
And a lot of people have talked before about, the big pitch will not be really to individuals, but to employers for their employees. How is that experience for you, making that pitch to employers about this different model of care?
In some respects, it's much easier. In terms of dollars and cents, employers tend to look at things, more based upon the numbers than individuals do. So in some respects, that's been easier. Employers do kind of add another layer. I won't call them totally a middleman, but it does complicate the relationship a little bit. However, given the current mindset and structure of our healthcare system, a lot of people are only comfortable getting their health care and or insurance through their employer. So it's a huge growth potential. And in fact, most of the docs who are growing quickly, or practices who are growing quickly, are doing it going after employers, because you can certainly sign up a lot more people if you get an entire business than if you get just one family. So I think it perhaps isn't the most ideal way that direct primary care would work. I would personally rather deal with families directly, but the growth potential in the market is much bigger through employers than getting one family at a time.
Now, you mentioned before we went live here that you do have a medical student there. Have you had a lot of interest from students and residents coming to see what you do and how the practice that you have there?
Yeah, a lot. I would say half to 3/4 of the students who rotate with me, and I have one on most months, did so specifically because they were interested in direct primary care, especially residents. I mean, almost every single resident that I've had rotate with me, it's been several schools here regionally, have said, I'm really interested in doing this when I get out of practice, and they wanted to see it and see if it's real. And I think that's a lot of it for patients and doctors. Whenever I describe what I do, say what we charge, say the services we offer, the initial response is that can't be true, and is that real? And so a lot of times it's just residents who hear what I do and they just want to come hang out and make sure that this is not like some fabricated story, and that there's real patients and a real doctor doing real medicine.
You said before, I forget where I was going to go with that. So the AAFP is starting to build some resources and things, and so if medical students and residents have questions about resources, is like the organization that you're a part of, are they building resources as far as
I think so. Yeah, I'm on the board of it, but I'm not sure exactly all of the plans. I believe that they're planning on doing some kind of some more educational things. I think they're going to have some materials on there. There's a lot of legal questions, although it's not as complicated as what people perhaps think. So I think the Direct Primary Care United organization is going to do that, and also maybe hold some seminars around the country for interested doctors, and have doctors like me who've been doing this for a while answer some of those questions. So yeah, and I think there's a number of other organizations who've kind of adopted, I guess you will say, direct primary care and championed it. But I don't think there's going to be just one organization, and I'm like I said, I think the AAFP getting involved is so crucial.
And we talked before that, I mean, it's having those negotiations with labs and with ancillary resources and X-ray and MRI, and you were doing a lot of that stuff starting up. I mean, it's you get a lot of questions from students about how do you deal with that.
Yeah, and that stuff, those ancillary things, although you have to give them thought and consideration, it really is not near as complex as what people think. I mean, as opposed to trying to jump through hurdles for prior authorizations and trying to navigate the coding and billing system. I mean, that stuff is infinitely more complex than calling your Quest representative and saying, hey, how much does this or that cost? I mean, they give you answers very quick. So really, people, that seems like a daunting task. Like, oh, I'm going to have to create this local network of X-rays. I mean that stuff took some work, but not near. I mean, doctors spend 3 or 4 hours every day dealing with prior authorizations and just gibberish paperwork and coding and fighting for reimbursement, et cetera. So, I mean, yeah, it's a little bit of work to set up some of those ancillary services, but I mean, I probably have done all of that in less time than what most people spend a week doing prior authorizations and insurance paperwork. So it does seem kind of daunting that you'd have to do that yourself. But really, depending on your location, I mean, I'm not in a huge town. Lawrence is about 100,000 people, and Kansas City is nearby. But I mean, I spent some time on the phone and saying, hey, if I send patients to you, or we could give you some business. How much would you charge for this or that? And really, to do primary care, to do family medicine, you don't need that much stuff. I mean, you don't need to get a price for a PET scan when you start up. I mean, really, 90% of what you need is pretty simple and straightforward lab work and limited diagnostic tests. So that's really not the difficult part of direct primary care at all. Even though from the outside it might look like that's a very daunting task to do those things.
So what are the difficult tasks of different?
I would say getting patients. This is a new idea, and I think that after talking to doctors who've started their practice in the last 6 months to a year, it's been easier because in the media and people are more aware of direct primary care. So whenever I started my practice, no one had ever even heard of this in my town. I mean, no one. There was another doctor or two down in Wichita. I'm not sure they were using the term, but no one had ever heard of this. I mean, when I described it, people are like, "What is this?" So I think now, just because it has gotten some media attention nationally, that doctors opening up their practices are going to have to do less education. There's a familiarity, and people are my first few patients were an interesting bunch. They were kind of taking a leap of faith in a concept they had never even heard about. So I think that getting patients has been easier from talking to doctors, but that's always the challenge, because you're not going to have direct referrals from Blue Cross. You're not in network for anybody, so it has to be individuals and/or employers who make that active decision. And so, yeah, I mean, that's the big thing is you got to work hard getting out and educating your community about what you're doing, and doing those networking and a little bit of marketing, although I don't think that's the most important thing. Is much different in direct primary care than in insurance practice. Insurance practices, they have too many patients and coming out their ears, and they're not really terribly worried about marketing and going out actively recruiting patients, whereas in direct primary care you have to, because no one's going to, they're not just going to fall in your lap.
No, I really didn't believe the office until I got there and saw it on my own. It kind of a little bit.
You thought I was like in a closet or something?
Well, I mean, I didn't know, because I mean, I saw pictures and stuff. So you have a waiting room, you have an exam room, you have a conference room, and you have a pharmacy. I mean, is it just as simple as that?
Yeah. Yeah, I mean, it really is. I mean, I've met a few doctors who started their practice without even a nurse. I mean, it was just them. And I'm not sure you can do that long term, but if you make things efficient and simple, I mean, you don't need that much room or space or staff. I mean, if you think about like what you do every day as a family doctor, I mean, 80% of it is talking and listening to your patients. And the stuff that you need for supplies, materials, procedures, medications. I mean, all that stuff isn't that complicated or take up that much space. So, we try to make the office comfortable and kind of a little bit more modern and relaxing. But it's not, it's one of those things, like I said, sometimes you have to kind of see this in action to understand exactly what it is.
And I remember that, a couple of stories that you shared that where patients were shocked that the doctor was answering the phone that when they called the office. What did they say?
Yeah, I mean, that was always, it still happens. Whenever I answer the phone and say New Care Family Medicine, this is Dr. New. Oftentimes the patients just kind of stutter and the doctor. I wasn't ready. I was wanting to speak to somebody else, and so I say, well, gather your thoughts and then tell me what's going on. So yeah, whenever prospective patients, I mean, our patients who've been members for a while, they kind of expect me to answer the phone almost. But patients who are used to the regular system and being so many layers removed from their doctor are just taken aback whenever they walk in because they're interested or they give us a call, and I can say, yeah, sure, come by at 2 o'clock and I'll sit down and talk to you for 20 minutes about what we do. Whereas even their personal doctor they couldn't spend 20 minutes with and they're paying them lots of money. So yeah, I mean, there's just a stark difference between the relationship and the time that we can spend with patients as opposed to the regular system.
Now, we talked before as well that when you document, you don't have to document to get paid. And is it a trend that a lot of these direct primary care practices, I mean, they're building their own documentation system, or they don't have to do anything that's very complicated than what I have to do in the traditional system?
Yeah. I've seen people do all things. I mean, I've seen a few docs who do paper charts. I like technology and think it can enhance things. So yeah, I mean, there's docs out there who've built their own custom systems. There's a few EMR companies who've kind of started approaching this market, but again, the regular documentation, coding, all of that stuff is so much more complicated that the tools that you need to do direct primary care are much simpler. I mean, we kind of I guess poke fun at like old-fashioned doctors who are using these little cue cards to write their notes on, like they were doing a bad job. But in reality, like the more that I practice in this model, the more I realize, like again, I don't want to go back to 4x6 cards to keep my notes on in a box, but there was a certain reason why they did that, and there's a certain art form of writing your notes and keeping things simple and straightforward. And it totally changes the way that you write your notes, honestly. And so it's only what's necessary medically. Of course, there's always some liability considerations, but most of it is just, okay, what happened, and I don't have to worry about checking a bunch of boxes. I don't have to worry about a 7-point review of systems to make sure that I get that 99214 reimbursement. So you can keep your notes much shorter and more direct and honestly better because you're actually writing your notes for clinical purposes, not for payment. And so you do write notes and you do record interactions and what you see, but it changes the way that you think about even writing your notes, and so you don't need complicated tools to do that really.
You mentioned liability, so did you kind of have to make a pitch to the malpractice liability insurance carrier and saying, this is what I'm doing?
No. And honestly, the malpractice carriers, and the one that I use is the largest one in Kansas, they really weren't specifically interested in how I got paid. They just wanted to know that I was a family doctor and here's the procedures I did, and kind of generally what my volume is. I had some discussions with them about maybe you should give me a discount because I see 6 or 7 patients a day instead of 37, and that means I'm less likely to make a mistake. And they didn't give me any discount, but really my malpractice in Kansas, you have to carry malpractice. You can't have a license without it. So my malpractice coverage, and I do a little moonlighting on the side and stuff. So I mean, my malpractice coverage is just like any other family docs would be. There was nothing unique because I'm a direct primary care doc. It has nothing to do with that.
And I know I get questions from students and residents too about this whole, being on call 24/7. Obviously, it's not like you're an obstetrician or anything like that. I mean, how often do you have to come in and take care of patients, in the office or whatever?
In person, very rarely, very very rarely. Part of that is just volume. So whenever a doctor says they're on call, what kind of you're used to, I mean, whether you're a resident or in private practice, whatever, is you're not just on call for like, your few hundred or few thousand patients. You're on call for an entire group. And I mean, I talked to a doc locally recently who's very interested in doing this, and she was taking call. It was only like once a week, I believe, but she thought her patient, I can't remember how many doctors were on the panel, but it was 10 or 15, which I'm not sure how that math works up for her. But anyway, maybe some of them don't do call at all. But she was taking call. She thought it was between 15 and 25,000 patients when she was on call. That would call her from all the other doctors who were in this call group. And so her one night of on call was hell. I mean, she get called every 20 to 30 minutes. Refill stuff that she didn't know these patients. She kind of had access to the records, but you know how that is. Can't really tell much from records, at least the way records are now. So I mean, her one night of call was exhausting. And my one night of call every night is a small group of patients who I know pretty well, and honestly, probably half of them, when they call me after hours, when I answer, I recognize their voice and I know their name, and honestly, a decent amount of their medical history just by their name and their voice. So being on call for me is much different than being on call for a group of people. It's usually something very simple. I can usually take care of it over the phone. And if I need to come in after hours, I can certainly do that. But it doesn't happen very often. I mean, I would say, I between the hours of 10 p.m. and 7 a.m., I probably only get called once every 2 to 3 months in those hours. Occasionally I have an early evening, phone call, someone who's concerned, and I have to say, don't be concerned, I'll see you in the morning. But in-person care, I mean, I haven't done an in-person care after hours in probably 3 to 6 months. So things like broken arms and stitches and those kind of things that need to be taken care of like immediately. They, in a group of 600 or 700 patients, that doesn't happen very often. And honestly, anyone who's worked in the ER can tell you that a lot of what ends up in the ER is primary care. I mean, it should have never been in the ER. And if the person thought they could have talked to a doctor and gotten good advice, they would have never went to the ER, and it could have been something that easily could have been handled the next morning. So really, our perception of like what could be handled over the phone and what ends up in the ER is so skewed because of the system that most of the time I'm really not that busy after hours.
We've talked about students and residents, but I remember you mentioning that you've even had docs come from out of town or out of state to come and see what you're doing there. And obviously, starting from scratch is kind of the easier type of thing how to start up. But when you talk to docs, who are in like in my situation, who are practicing in a situation now and who are interested in changing either part of their practice or their entire practice to direct primary care, what kind of advice do you give them?
That's probably one of the most difficult decisions to make. I mean, doctors who are in practice, who have a stable practice, and who are making a steady income, transitioning direct primary care is a risk. I mean, you're starting a new business, and it's hard work, and you're not probably going to do it overnight, and you're not going to automatically, the first month be making what you made in your traditional practice. So there's risk in it. I mean, anyone who opens a small business can tell you that, whether you're a doctor or a plumber. But I think if it's done right and it's given some thought and you consult with the right people, I mean, I think it's very feasible and doable. But you have to be committed to it. I mean, you have to be committed to it personally and business-wise. I generally discourage people from doing hybrid models. And by hybrid, I mean, you kind of have your traditional practice, like you're in a private practice, you have 17 insurance contracts, et cetera, and then kind of offering a membership or direct primary care plan on the side. There's certain docs who do it. The issue that I see with doing that is that you're not fundamentally changing, again, the way you practice, because you have this certain group of patients who are under this plan, and it almost just becomes like another payer model. And so you kind of have this segregation of patients. Well, there's these type of patients and there's these type of patients, but you still have to carry, your insurance contracts, which kind of, limit what you can necessarily do for those patients. And so I generally think that that's probably not the best way to go, but there are docs who do that because they're, they don't want to take that full leap. And I think it can be done that way. But, my practice is me and one nurse. And there's no way I could run a hybrid practice and do a few insurance contracts on the side, and I wouldn't be able to necessarily do the 24/7 access if I had 3,000 patients, and I wouldn't be able to spend an hour a day responding to emails and text messages if I had kind of my regular insurance patients and then my direct patients. So I think it's probably not the best way to go. I think it's better to go all in and do fully direct. But there are certain organizations and people out there who promote doing that as kind of a transition phase. But I think it's probably better done all at once.
And so none of your patients have any other insurance plans at all?
Oh, no, a lot of them do. A lot of our patients have insurance. It's just they get better care and often for cheaper with us. So again, one of the big misconceptions, this one will be on the AAFP blog post, I'm not anti-insurance at all. And in fact, I think insurance could be much better and cheaper if we change the way that we think about it and use it. So a lot of our patients have insurance, and some of them have so-called good insurance, but they still can't get what they get here with their insurance, either financially or service-wise. So I encourage all of my patients. I personally have insurance. I just think for primary care, it can be done so much better and cheaper most of the time if you don't involve it. So it requires I guess to step back and realize that health care and health insurance are two different things. They're totally different things. But both doctors and patients oftentimes have trouble distinguishing, and they'll use those terms interchangeably. and when I say that, it seems like, well, no, duh. Of course, health insurance and healthcare aren't two different things. But that's kind of unfortunately how we view them, and that it's an all or none situation, with or without. So, I think that most of our patients who have insurance find that if they move to a higher deductible plan, which some people are moving to regardless, whether they want to or not, oftentimes save money. So their total amount that they spend is much less paying our modest membership fee and a high deductible plan, and they're getting better care, and they're getting wholesale meds, and they're getting a doctor 24/7, and they're saving money. So that's where it's very difficult, and that's one of the first questions is, well, what happens if you get run over by a bus? Well, what happens if you need a specialist? Well, primary care is primary care, and a level 1 trauma unit is a level 1 trauma unit. They're two totally different things. But I think that just recognizing that perhaps insurance is not the best way, especially fee for service, is not the best way to do primary care. It's a hard thing for people to realize. But our patients who do have insurance, if they have a PPO style plan, which most people do, they can use their insurance just like anywhere else. If I end up referring them somewhere, my goal is to take really good care of them and do everything they need and minimize the amount of hospitalization, specialists, et cetera, that they need. So I think it's not an either or situation. But I think that's unfortunately how a lot of people think about it, including some of my patients.
So that is one of the misconceptions, is that that this model is really aimed and direct towards young people without insurance. But what you're saying is that you have patients who have insurance and who are taking advantage of the style of healthcare that you deliver.
Absolutely, and that's the other. It's funny because if you actually break it down, I charge a flat rate membership fee no matter how many visits you have. So older, sicker people are getting a much better value than young, healthy people. So whenever I describe what I do, some people say, oh, well, that'd be great for really young, healthy people who never need a doctor, and then other people say, oh, that'd be great for someone who had diabetes and depression. I think it's great for both. If I save that young person from an ER visit, who's carrying a high deductible health plan, I've paid off 3 to 5 years of their membership. I do that routinely. If I have a person who has ongoing chronic needs and frequent visits, it's a no-brainer for them. They're getting free chronic labs. They're getting no copays. The amount that they pay me is less, even if they had a so-called good insurance plan. So I don't think that there's like a specific niche that direct primary care is going after. My patients are sicker and poorer on average than even the regular insurance-based practice, which people from the outside have lots of ideas about what this is and who we're serving. My patients are more uninsured than insured. We have both, but they tend to be sicker, and they tend to have very complex problems that haven't been very well managed, or problems that have never really been diagnosed. I've actually found the opposite of what most people perceive in my practice.
As you start to kind of close up our conversation here, tell me a little bit more about specifically New Care Family Medicine. Do you offer individual plans, family plans, both? Can you give a little bit more detail about your?
Yeah, so basically for individuals, our membership fee is $30 to $60 a month based upon the age. So young adults and kids are only $30 a month. In ages 26 to 44 are $40 a month. And then $50 a month between that and 65, and then 65 and up is $60 a month. We do offer I love families, and I want to get as many as I can. They're great patients, and that's why I do family medicine. So we give them a pretty good discount. So a family of 4 is only $120 per month. So and for that, we're basically, like I said, we're doing unlimited visits. I have a small fee for house calls and after hours, but unlimited office visits with no copays. Most routine diagnostic testing, including EKG, point of care testing, lipids, A1C, TSH, and then for the things that we do charge for, it's at cost. So if we do a procedure and there's no big supplies, it's nothing. If we do like stitches, for example, it's about $10 in supplies. If we do medications, we do our own wholesale medications. We sell pretty much at cost. So that's like a 70 to 90% savings. Stuff on the $4 list at Walmart is $1 a month with us. We do 10 Imitrex for $8 a month. Flonase is $6 a month. So as you can see, anyone who's taken 2 or 3 medicines, honestly, is probably saving more money with the membership fee than what they're paying me.
That's great. That's great. And my last question for here, Dr. New, is having to do with family medicine, and you've talked about it for the whole hour, but kind of as a closing thought, why family medicine for medical students? Why do you love family medicine specialty?
Well, I think when you really boil it down, the best thing about family medicine to me is we control our own destiny. There's lots of moving parts in the healthcare system, and I can't predict how all of that stuff will shake out. But I think family docs are in a really unique position to control their own destiny. This is my vehicle for doing that. But I think both systemically and individually, family docs have more power. We can do something like this. I mean, I can so-called go off the grid and say I'm going to provide better care for my patients. If you're a cardiovascular surgeon or some subspecialist, although I guess your income immediately might be better, you don't really control your destiny near as much. You have a few different types of environments you can work in, but as a family doc, both in terms of business and just career choices going forward, you really can tailor your career as you want.
And if people want to learn more about Dr. New, where can they find out that information at?
I'm all over the interwebs. So if you Google me, you'll find me. But you can go to my website, which is newcare, neukare.net, Twitter @newcare, and then Facebook.com/newcare. So yeah, you can reach out to there. If you want to give me a call, you can call through my practice phone number anytime, or shoot me an email, drdr.new@newcare.net.
Thanks a lot, man. It's great talking with you again, and next
Say
time
hi,
come
medical student.
There we go. Yay!
Third year, first rotation. First rotation.
Really? Wow.
So do you think this rotation will be like the rest of hers? What do you think? Probably.
This will be the best rotation ever.
Well, what I told her is it's going to make all the rest of her rotations more difficult because she's going to ask all these really annoying questions like, is the C. diff GDH test as screening a cost-effective method instead of just going straight to the PCR? And she's going to ask questions like this, and they're going to say, "What are you talking about?"
Oh man!
That's the kind of conversations you have when you do what I do.
Exactly. Thanks so much for the time, man. We'll talk very soon. Thanks a lot.
Bye bye.
All right, kids. So that ends our show here today, and so yeah, it's always great talking with Dr. New, and I always feel very guilty because I always slaughter his name every time I introduce him or have him on a show. Like I'm like the worst interviewer ever. So go to newcare.net. And I'm going to put this video up if you haven't seen it already on DrMikeSevilla.com. And also on Twitter and Facebook and all that stuff. So yeah, I'm having fun interviewing people again, and hopefully I can kind of keep the momentum going. And hopefully people will continue to say yes to talk to me about whatever they want to talk about, especially my friends in the family medicine revolution. So that's it. DrMikeSevilla.com. Follow me on Twitter, Dr. Mike Sevilla. Have a good day, everybody. Bye.